Anybody else need notes?
Usually I skip off while that.
Just
Notes, anybody? I'm selling them. Guess they'll come back up if they
Oh,
need
yeah.
Whatever. Oh my goodness, that picture makes my eye hurt every time I look at it.
straight.
Oh. All right, let's get started. We have a lot to get through today if we want to get it early Thanksgiving break. So, I spent some time this weekend going over the lectures for the rest of the semester and trying to divide things up and figure out how we could do it. And I did, so it's official. We will not have class on Friday this week. So lab will be the last thing we have for the day. And remember, our quiz is on Wednesday. So give us a little extra break time. I like that idea. Right. Let's start this week off with a prayer. Gracious Father, we come to you in our weak humanity, and I pray that you will give us the strength to finish this semester out strong. Give us the strength for this week. Help us to learn. Help us to grow. Guide us that we might, in everything we do, honor you. In Christ's name, amen. Okay, so we talked about face muscles last time. Now let's talk about some of the innervation. So some of the innervation I'm kind of going to gloss over a little bit because hopefully, it sounds like it'll work, going to get a dentist to come in and talk about sensory innervation of the face and doing nerve blocks in the face. And apparently I'm going to be the guinea pig, so it's going to be an interesting class period.
Oh gosh.
Yeah, so should be fun. I hope it works out. For me.
For me.
So, just remember a lot of our sensory information comes through the trigeminal nerve, and this is what she will talk about predominantly. So here's our trigeminal nerve here. And we have three branches. We have the ophthalmic nerve, the maxillary nerve, and the mandibular nerves. And so each one of those, its name kind of betrays some of its innervation, and I will let her get into the details of that. And just remember those three branches. And when she talks about which areas they innervate, make sure you're paying attention to that, because that'll be fair game for quiz questions and test questions.
Do you know when she'll be coming?
Not yet. We're still working on the date. All right. So since we have sensory innervation from the trigeminal nerve, obviously we're going to have the cutaneous branches. And so this is just, again, looking at the overall dermatomes of the face. Remembering we have our various dermatomes. So for V1, we're going to kind of have this front of the scalp, orbital area, nasal area for the ophthalmic nerve, for the cutaneous distribution, and then temporal and zygomatic regions for the maxillary, and then finally the mandibular, kind of taking care of some of the rest of the face and some of the sides of the scalp. And then we have posterior rami, taking care of all of this blue area here. It would be all posterior rami of the spinal nerves, cervical spinal nerves. So. And then the yellow part here would be all anterior rami. In the first section, there was a figure that was a little clearer about, which of the spinal nerves contribute to each one of these dermatomes. Make sure you're familiar with that. We don't need to get into the detail of, like the third occipital nerve. That's more than what I think you guys need to know. Just know the spinal nerves, like what we had in the first lecture. So here are those regions for the three branches of the trigeminal nerves again. And then here are three autonomous zones. Remember, those autonomous zones are regions where we can test for loss of function in those dermatomes, loss of sensation, and being fairly confident that we're not getting overlap from other dermatomes. Okay. All right, motor innervation for the face, remember, is from the facial nerve. And I'll just point out there are 5 subdivisions or major branches of the facial nerve. So in its early portion, it's almost plexus-like, so it does some interconnecting of branches, but it comes out with 5 major terminal branches, these here. These are terminal branches. And each of these terminal branches is labeled, the name is indicative of the region it innervates. So you let that help you remember them. So temporal branches, obviously temporal area. Zygomatic has to do with the cheek, over the zygomatic bone region. Buccal is a word that refers to the lower part of the cheek and the mouth area. So this is our buccal region right here. So these would be our buccal branches. Mandibular, obviously the lower part of the jaw, and these cervical branches, they innervate the platysma, one of the superficial muscles of the throat region that helps with facial expression. Excuse me. So know those 5 main divisions, and you let the names help you remember what they innervate. All right. What happens when we have damage to those nerves? One common mononeuropathy is Bell's palsy. So this is an example of Bell's palsy. It's the most common mononeuropathy in clinical practice. And mononeuropathy, what does that mean? So mono would be one nerve, right? And then neuropathy, inflammation of, or something interfering with the function of that nerve. It's typically unilateral. So you can see here, if I erase my word here, you can see that just this side of his face is showing some drooping in the facial muscles. Okay. Bell's palsy is specifically a neuropathy of the facial nerve. Okay, or some branch of the facial nerve. So this would probably be, I would guess, some of the buccal section, maybe some of the zygomatic section of the facial nerve. Typically, they think it's caused by some sort of viral infection that comes in and paralyzes the nerve by causing inflammation and then consequently compression of the nerve, and that's causing the palsy. It typically resolves itself within 2 to 6 weeks by itself. So so you would see this kind of permanent droop if you would have actual permanent damage to those facial nerve branches, like say removing the parotid gland tumor or something like that. Okay. Questions about innervation of the face? Anything? All right. So vascular supply and drainage is pretty easy. Kind of talk about it together because the veins and the arteries travel together, very, very close approximation. So the major artery is the external carotid artery, and then our major vein would be the external jugular vein, supplying and draining the whole region. And then we have 3 sets of branches that I want you to know. I want you to know the facial artery and facial vein. So that's going to take care of kind of the lower mid portion of the face, so nasal region, coming up into the orbital region here as well. And then we have the superficial temporal artery and vein. I take care of the temporal region and more of the zygomatic region. And then we'll talk about this when we get to the scalp. We'll also have the occipital artery and vein kind of taking care of back behind the location of the ear. Okay. The rest of the small branches, you know, if you go into face, something with specialty with the face, you'll learn them, but this at least is the major ones. Okay. One more branch of the external carotid artery that is deep, we couldn't see in the other, is the maxillary artery, and that's going to then supply the maxillary region here and zygomatic region. Okay. And then just a reminder that many of those veins, they may be draining down to the external jugular, most of them. Some of them also go straight back into the cavernous sinus and the pterygoid plexus of veins. Again, remember, these are regions draining some of the internal structures, especially those dorsal, oh, can't remember the name of those, venous sinuses, or the dural venous sinus, wow. Okay, and so then we'll also get drainage into the internal jugular as well. And remember that these, like the ophthalmic veins and those are emissary veins, meaning it's kind of a direct shot from the surface of the body to some of these interior sinuses like the cavernous sinus, and can be a very easy route for infection to come into the body. All right, lymphatic drainage, basically 3 sets of nodes for the lymphatic drainage of the face: the submental nodes, submandibular nodes, and then the preauricular and parotid nodes groups. We'll share the preauricular and parotid nodes with some of the scalp when we talk about that, but then just being aware of these nodes. These and then the nodes that drain the scalp actually make a ring of lymph nodes around the base of the head. And since there's so much contact of surface structures of the face with the outside environment, so you know, the eyes, the mouth, the nose, all of the ears, having good lymphatic drainage of that area is going to be obviously important. All right, so then on to the scalp. You need to know the layers of the scalp. Fortunately, it's a nice mnemonic. The name of the scalp is this nice little mnemonic. They have it spread out here. Great, I love it. So obviously you have the skin on the surface, and then we have a layer of dense connective tissue. The aponeurotic layer is the aponeurosis of the, excuse me, the occipitofrontalis muscle. I spelled that wrong, I'm pretty sure. Yep, occipito. There we go, frontalis muscle. And then under that we have a layer of loose connective tissue. This loose connective tissue is actually why you can move your scalp across the skull a little bit, get a little bit of movement there. It also happens to be a nice area for fluid to accumulate if there's some sort of fluid leakage, like a hemorrhage or something. Often this is where you'll have accumulation of the fluid. And then finally we have the pericranium, and the pericranium is just a term for the periosteum on the outside of the cranium. And remember, the periosteum is that thin membranous layer over the top of the surface of the bone that helps as a pathway for the vessels that supply the bone. Okay. All right, so that's the scalp. Remember, we have our occipitofrontalis muscle and the called epicranial aponeurosis, so that layer of aponeurosis across. And just a couple things to note about that. Not only does it allow for some movement of the scalp, but also just some notes about fluid accumulation, fluid drainage in the region. So the occipital belly, this portion right here, actually is attached to the bone here. And so it provides kind of a firewall, so a kind of a barrier for fluid drainage. So typically if there's bleeding or something like that, the fluid's going to pool in this region here and not get down into the neck region. Okay. If we look at the frontal belly, also known as the frontalis muscle, you know, some people call these still separate muscles, the frontalis and the occipitus. There is no barrier here, so you actually can have fluid accumulation in the eye region here, because there's a conduit just going straight through down from the scalp down into the orbit. So then we can have injuries like this, where this individual has a laceration on her scalp here, and you can see how there's been some fluid drainage and it's pooled in the region around her eyes because of that conduit there. It's rather awful. All right, so those vessels draining the scalp. So before we saw the superficial temporal artery and vein, so it has several branches that drains the mid portion and the lateral portions of the scalp. And then here are our occipital vein and artery to drain the posterior regions of the scalp. The anterior regions here are drained by a branch of the facial artery and supplied by the facial artery and vein. Okay. All right, and then finally lymphatic drainage. Again, we see our preauricular and parotid nodes, and then we add the mastoid and occipital nodes. And now you can see that full ring around the base of the head. Those then all drain to the deep cervical nodes, which are all kind of lining this region of the neck. And actually the next figure shows these. So here would be our deep cervical nodes here. All right. You don't need to know all of these. This is more than what we need to know. There we go. So we just need to know these: occipital, submental, submandibular, and parotid and auricular. And then we'll just collectively call these the deep cervical nodes. Okay. Questions, comments? Okay. So that is scalp and face. Now we're going to get into specifics about the eyes, ears, and nose. So we'll go through each one of those, and then finally the oral cavity. So skeletal framework of the orbits. Again, you don't need to know the details of these bones beyond what you have to know for lab, whatever's on the lab list. What I want to point out here is these are often very delicate bones, and so they can be easily disrupted, especially this medial wall and the inferior walls. Okay, those are especially susceptible. Okay. So then, if you have something increasing the intraorbital pressure, you can have the blowout fracture. And I swear, this every time I look at this, it makes my eyes hurt. Oh my gosh. Ow. And so you see here, this is an inferior wall fracture. This is the most common wall to be fractured, followed by the medial wall. The lateral wall, very, very infrequently. So those are a little bit stronger, a little bit more resilient bones on the lateral wall. Okay. All right, so then, kind of working our way more specifically, the anatomy of the eyelids. So it's not just a flap of skin. It has its own little skeletal framework of a sort. So we have the tarsus here, and this is connective tissue. Fairly dense, and so it kind of gives the framework for the eyelid, helps it retain its shape. It is on the upper eyelid. It is controlled by the levator papillonae superioris muscle. So this is our main voluntary muscle, so somatic innervation. This is how we voluntarily can raise our eyelids. And then we also have the superior tarsal muscle, which is autonomic, innervated by a sympathetic nerve. So this is going to be involuntary, and so extra wide opening of the eyes when somebody's afraid partially is because of that somatic innervation of that muscle causing eyelid to open. By far, this is the stronger of the two. The levator papillonae superioris is the stronger of the two muscles, so it predominates. And yeah, I think here we go. We have just an image so you can see the spread of it. So we have the superior tarsus, that tarsus there, kind of going along the whole upper margin of the eye, and then we also have the inferior tarsus mirroring it down below the eye. And you also can see here the tendon of the levator papillonae superioris coming down and spreading out to connect to the eyelid. Okay. Right, so then we have a few glands we need to think about. So we have the tarsal gland here, and this is our small glands embedded in the tarsus. They're a sebaceous gland, which means they secrete a waxy, oily substance, sebum, to help lubricate the eye, the surface of the eye. And then we also have the sebaceous glands of the eyelash, so those are actually associated with the follicle of the eyelash that also contribute to lubrication of the surface of the eye. Now, since these are glands, they can get plugged, and so we have a couple of manifestations of that. So when we plug the tarsal glands, we get a chalazion. Another word for the tarsal glands is the meibomian glands. And so if you wanted to use the technical term, this would be a meibomian gland lipogranuloma, because we've got a fatty substance that's blocking the duct, causing this accumulation of inflammation in immune cells. That's the word I was looking for, which was the definition of the lipogranuloma. Okay, and so it's going to be a little bit higher on the eyelid, sometimes kind of on the interior surface of the eyelid, as opposed to when we block the sebaceous glands of the eyelash. Come on, Dave, there we go. Where we get a smaller lipogranuloma that's closer to the margin of the eyelid. I mean, I'll know this as the thigh. Questions, comments, funny stories? Okay. All right, so then also to lubricate the gland, the surface of the eye, we have the lacrimal gland. And this is obviously produces tears. So it's sitting up here, kind of the superior lateral position in relation to the eye, and has multiple ducts leading to the orbit, the interior of the orbit, so secreting the tear secretions. And they move over the surface of the eye and are collected by this group of structures here. So the puncta are openings that allow the lacrimal secretions to move into the lacrimal canaliculi. They then pool in the lacrimal sac and then drain through the nasal lacrimal duct into an opening in the lateral nasal cavity. Okay, so this goes to the nasal cavity. And so blockage of these ducts would then cause excessive tearing because we aren't able to drain the lacrimal secretions. All right. All right, the lacrimal gland is autonomically innervated, so we have both sympathetic and parasympathetic innervation to the lacrimal gland. The parasympathetic innervation is the dominant innervation. So and it comes from remember, from the facial nerve. Okay, so this is predominantly coming from facial nerve fibers, and they join in with the maxillary and then branch off of the maxillary to go through the zygomatic to the lacrimal gland. We also have sympathetic fibers that come through the same basic pathway here. Up joining briefly with the maxillary nerve and then traveling on to the gland. Most important to remember though is it's autonomically regulated, so obviously we don't have to think about whether our glands are tearing or not. Unless of course something's blocked. All right, questions? Nope, okay. All right, so let's talk about the eye itself, the eyeball itself. So motions of it, easy ones, elevation and depression. So elevation moving superiorly, depression moving inferiorly. Medial movement is what we call adduction. So, and then abduction would be lateral movement of the eye. So those are the ones that are obvious. And then we have external and internal rotation, and though they are possible, they're not typical. So we don't usually see a lot of internal, external rotation of the eye, even though it is a possible movement. Okay, so what's controlling that motion? One thing to note is, so here's the front of the face here, nose sticking out. So the eyeballs are kind of on the axis perpendicular to the surface of the face. This we call the axis of the eyeball. The axis of the orbit, though, is at an angle here. And since the muscles controlling eye movement, most of the muscles attach here at the back of this orbit, so kind of at the apex of that orbit. And these would be the extraocular muscles. Those muscle contractions aren't going to be as straightforward in what they cause as they could be if they came back and attached here. So the muscles actually come and wrap around and come back at an angle from the eye. So here are the muscles. So you see most of them come back and attach to this region here at the back of the orbit. We have 4 rectus muscles. So we have the lateral medial, superior, and inferior rectus muscles. And they are a little bit more straightforward in what they cause. And then we have two oblique muscles. We have the superior oblique and the inferior oblique that kind of wrap around the eyeball. So with the rectus muscles, they kind of attach to the eyeball here and then run straight back, I mean, at least as straight as they can at the angle they're at, to this attachment point here. The superior oblique does originate at this common location, but then it comes through this trochlea here as a pulley system and then attaches to the eye kind of at its lateral superior region here. And this allows for some of that potential rotation. It also helps to balance out the angle here that the muscles are coming off the eye. So superior oblique, remember two bellies, so one belly here, this intervening tendon that goes through the trochlea as a pulley system. And then the inferior oblique attaches to the orbit, the orbital cavity, kind of on the medial portion of the orbital cavity, and then wraps around the bottom of the eyeball and attaches to the lateral portion here. So then, what do they each do? So here's, in general, the direction that these each pull the eye. So abduction is predominantly the lateral rectus, so pulling the eye away from midline. Adduction towards the midline is predominantly the medial rectus. Though the superior oblique and then the inferior, superior rectus and inferior oblique all kind of help with that because of the angle that they are at. Depression is a combination of the inferior rectus and the superior oblique working together. And elevation is a combination of the inferior oblique and superior rectus working in combination. So the superior rectus pulling the eyeball up, the inferior oblique preventing the eye from moving. So it'll be easier if I look at the pictures here. So the superior oblique pulling the eye up and the inferior oblique preventing the eye from moving laterally during that elevation. Okay. Questions? Kind of non-intuitive at first. Okay. Right, so sometimes the eye muscles aren't quite the right length or are attached to the slightly incorrect location, and this would contribute to a condition known as strabismus. So that would be like cross-eyed or cockeyed or something like that. And so they can go in and move the eye muscle to correct for that and realign vision. So strabismus is just any condition that is a misalignment of the eyes in their from normal alignment. And so what they would do is either move the muscle back, so excise it and then reattach it further back on the eyeball. This would be called muscle recession. Or they can resect a portion of the eye and the eye muscle and in effect shorten that muscle, and this would be resection. And I personally am very thankful for this surgery because I was born quite cross-eyed. Some of my baby pictures, I'm like, wow, that was not normal. And so I went through this surgery when I was 6 months old, and that's why I can see out of both my eyes today. It's pretty nice. I like it. They did unfortunately go a little too far with the left eye, and so I can sometimes get it going out in this direction here. It does what it wants, whatever. At least I can see out of both of them, which is more than what the doctor wanted. The doctor who first examined me was like, oh, just let her go blind in one eye. And my mom's like, excuse me, I don't think so. So I'm thankful she didn't listen to her doctor.
So which one did you have? Sorry.
Both eyes. They overcorrected on my left eye, and so it tends to wander out to the side, especially when I'm tired. So if I'm looking at you and my eye's doing something over here, not me, I'm looking at you. It just does what it wants.
It was resection?
I don't know whether they did resection or recession of the muscles. I don't know the details of the surgery. I just know I'm really glad that they did, so I can see out of both eyes. They did wait until 6 months, which is unfortunate because that's when the critical period for your visual, your sensory cortex to be developed, and so I have very little binocular vision. So everything's a little flatter than anybody else would see probably, but at least I can see out of both eyes. Yeah, so pretty cool that they can do that. It's rather amazing. Okay, so then we can also test each of those muscles. So not only can they just be wrong from the get-go, something can go wrong in the course of life. So often it's because of like a nerve paralysis, and so we can test whether these muscles have some sort of weakness in them by these particular movements here. So this table, to test, say, the superior rectus, you'd ask the patient to look up laterally and upward. And if they are unable to do that, that would then be indicative of some sort of damage to the nerve supplying the superior rectus or to the superior rectus itself.
So like
Mm-hmm.
in the book where it says superior rectus moving it, doesn't it say it's moving it up medially?
Yeah, so what's going on with this is it's a combination of causing that muscle to contract and putting all the other muscles in a position of weakness where they can't be influencing the movement of the eye as much as possible. So if we look at, there's a table in your book that lists the functions of each of the eye muscles.
Mm-hmm.
What page is that? Mm-hmm.
I think it's on page 8.
888, yes, look at that. Okay, so you can see that, like the superior rectus, not only does it elevate the eye, but it's also involved in adduction and medial rotation of the eye. So if we want to check for just superior rectus, we have to weaken all the other muscles that are assisting with those movements. And that's, going back to the fact that these muscles are pulled off at an angle, so they're all working together to create these, what we would think of as simple movements.
Mm-hmm.
And so by looking laterally and upward, we're weakening all those other muscles that would be helping the superior rectus. Make sense? Okay. So this is going to be important. I don't know, have you guys done anything like this in HCPCS yet? Yeah. Okay. So you guys obviously know that's important for clinical. So I'm going to be focusing again, like they do in HCPCS, on the actual clinical application of it, not just knowing what muscle does what, but what happens when something goes wrong, kind of thing. Okay. All right, and then last slide for today, looking at vascular supply and drainage of the orbit. So we have the ophthalmic artery as our main artery coming in and supplying, and this is a branch off of the internal carotid. There we go. And then it branches off into a bunch of different things, but just know ophthalmic, that's enough. And then we've seen this a couple times, so the ophthalmic veins all come back to the cavernous sinus, the pterygoid plexus, and then from there into the internal jugular vein. All right, any questions about anything? If not, it's been fun.
No. No, I just need to see on my mind. Everywhere. Yeah, we're out.
I need to be. Like we had list out, we have that paper due, we have. But like, you take like oh yeah. Like I'm gonna try to get my paper.
Once the castle's done. Yes, yes. I don't know exactly. I mean, that's what it was. Yeah. You know. So. Yeah. Yeah.